Good afternoon, everyone. I am Dr. Indrodeep Boshak, here to present a study on pseudophakic cystoid macular edema rates in different intraocular lens used. I'd like to keep it short and simple, so I wouldn't want to elaborate on the intro.
Okay, thank you very much. And now we will go on to the second presenter, that is Madhurima Kumar. She will be presenting on serratia mercedens endophthalmitis, curious cases of pink hypopia.
Very good afternoon to all the chairperson, my seniors and my mentors and the delegates present here. I will present a case on serratia marcescens endophthalmitis. So what is serratia marcescens? Sir, excuse me. So I had modified the presentation. This is not my...
You just verify there. Probably I will call the third presenter. You verify there and be ready with your presentation next. Dr. Rishabh Mishra. We'll give that chance for anyone who is, give them chance to present afterwards. Rishabh Mishra, he will be presenting on Davis versus conventional analog microscope, our experience at tertiary care center in Eastern India.
Good afternoon, everyone. Today's topic for presentation is distally assisted vitreoretinal surgery versus conventional analog microscope, our experience at tertiary care center in Eastern India. As retinal surgery is a very intricate procedure in which we need a high level of dexterity, so we need a good visualization system. In our study, we used a Ingenuity system from the Alcon, in which the eyepiece lens is replaced with high definition camera, which project the image on 55-inch screen that can be seen by polarized glasses. In analog microscope, we use OPMI Lumera T, and PP machine we use is Constellation from the Alcon. This study is prospective hospital-based cross-sectional observational study in which we take 10 participants, 5 were the postgraduate senior resident and 5 being the vitreoretinal surgeon. We perform the 5 surgeries on each platform in which we perform pars plana vitrectomy followed by retinal detachment surgery and macular hole surgery. At the end of surgeries, each participant was asked to fill a questionnaire that was pre-designed questionnaire that was tested on 10 observers who were similar in experience to the study participant. The final questionnaire included the 10 items under the 4 sections, namely level of comfort, clarity of image, stereopsis, and understanding of the surgery. Replies of these questions were arranged according to Likert scale from 1 to 5, with 1 being the strongly disagree and 5 being the strongly agree. So it is quite evident in our study that 60% participant felt discomfort while using the cam, while the 20% participant felt discomfort using the DAVS. 70% participant achieve a good stereoptic image while using the DAVS, while 20% using the same with the cam. So the surgical steps understood by the 90% population understood the surgical steps very well while using the DAVS, while 60% using the cam. 70% participant preferred to further watch the surgeries by the DAVS platform, and while the only 30% preferred to do so with the cam. So it's quite evident from our studies that DAVS has many advantages over the cam, like better stereopsis, better depth of field, enhanced field of view, and better resolution and improved ergonomics. So there are some limitation of my studies, that our questionnaire were designed that way that they have given the equal weightage to all. And the questionnaire were prepared based on the opinion of retina surgeon experienced in using the DAVS platform. So the conclusion, DAVS is actually DAVS is a better learning and teaching tool as compared to the CAM, and that can be a game changer in the vitreoretinal surgery. These are some of my references, and thank you.
Do you have the questionnaire?
No, ma'am, I don't have right now.
So at least to me, it is not clear whether you are analyzing the surgeon who's operating, whether you are analyzing the operating, the experience of operating on the DAVS, or you are analyzing the somebody watching the surgery on DAVS passively.
Actually, I'm analyzing the surgeons who are watching the surgeries.
So
And,
somebody else is operating, they are only watching.
Yes.
Okay. So then the discomfort and all you have mentioned about the seating posture, ergonomics, that is for surgeon or for the person who is watching?
For surgeon especially, not for the observer actually.
But your questionnaire was for the observers, right?
Yes.
But you have talked about ergonomics. That's what madam is asking. Ergonomics can be only for the surgeon.
Yes.
So you cannot put a conclusion on ergonomics based on your study.
Yes.
Okay? Because ergonomics, the surgeon has to give his experience.
Yes, sir.
How did you arrive at the questionnaire? How did you validate the questionnaire?
Sir, actually, we have prepared the questionnaire basis on the experience of our vitreoretinal surgery.
There is, whenever you administer any questionnaire in any study, it need to be validated first.
Yes.
Otherwise, the structured questions, whether it will yield a reliable result or not, is uncertain. So you need to validate any questionnaire which you are administering, that was done or not done. Answer is yes or no.
No, I am not validating that.
You need to put the questionnaire with each Likert scale for each question has to be mentioned. I think in your full text also there is no mention of that. Each question and what was the Likert scale for each question. How many percentage have said strongly agreed, how many said strongly disagree, all that is important. That all those details should be given.
I have put it the percentage of the participant.
You have only 5 observers in each group, right? So the numbers are also too small.
Total sir 10 observers.
So these numbers are also too small to come to any conclusion.
Yes, sir.
See, the
Always.
questions are also so different, no? You are analyzing the surgeon and analyzing the participant, discomfort, stereopsis. So each question is a separate thing. You have to give each separately statistics for each question. You cannot club everything together and say 70% were okay with the questions.
That's where validation comes. The weightage of the questions will be given. Thank you very much. Yeah. Now is Madhurima Kumar is ready? Yeah.
Most of these are theses for them.
Sorry for the mishap last time. So I am Madhurima Kumar from AIOC2024 and I will be presenting a topic on Serratia marcescens endophthalmitis, the curious cases of pink hypopyon. So what is Serratia marcescens? First, it is a gram-negative opportunistic nosocomial pathogen which is aerobic belonging to the Enterobacteriaceae family. What is important about it? It is capable of producing a pigment known as protegiocin which ranges in color from dark red to pink depending upon the age of the colonies. It is a rare but devastating cause of endogenous endophthalmitis due to its ability to produce beta-lactamase, which suppresses the use of many broad-spectrum antibiotics. Now, the rapid advent of anti-VEGF agents to treat multiple retinal pathologies, as we all know, has resulted in an increase in complications as well. So, coming to my cases. My case 1 was a 58-year-old male who presented on post-op day 2 of intravitreal injection aflibercept. He was a known patient of type 2 diabetes mellitus. His chief complaints were pain, watering, discharge, and blurring of vision in the right eye. On presentation, his visual acuity was hand movement with PR accurate. As we can see here, he had a sluggishly reacting pupil with microcystic corneal edema. The slit lamp examination showed a pinkish red hypopyon. There was grade 4 vitritis on fundoscopy. An ultrasound B scan revealed clump of exudates, which is suggestive of endophthalmitis. So what did we do? We performed aqueous and vitreous tap with simultaneous intravitreal injection of ceftazidime and vancomycin. The culture from the both aqueous and vitreous tap revealed growth of a pigment-producing Serratia marcescens. As you can see, it is bright red in color on nutrient agar. And these were the biochemical tests performed, which revealed it was Voges proscure, urease and citrate positive, and hence It was a strain of Serratia marcescens. Coming to my second case, a 68-year-old male presented on post-op day 1 of left eye intravitreal injection ranibizumab with pain, watering, sudden loss of vision in left eye. His visual acuity was PL only. As we can see here, the anterior chamber was full of debris, pupillary membrane, fibrinous exudates, corneal edema, and there was a hypopyon which gradually changed color. So we performed a vitreous tap with intravitreal injection of ceftazidime vancomycin, and pars plana vitrectomy was performed, but to no avail. As we can see, cornea was melted. On the evisceration specimen, we found a growth of Serratia marcescens. In case 3, a 64-year-old female on post-op day 2 of intravitreal ranibizumab presented with pain, swelling of lid, and sudden loss of vision in the left eye. Her visual acuity was hand movement with PR inaccurate. There was circumciliary congestion, anterior chamber was full of cells, flare with pink hypopyon associated with severe vitritis. We performed vitreous tap, aqueous tap, and sent for routine biomicroscopy. The culture revealed growth of Serratia. Here we applied fortified amikacin 2.5% drops hourly, and pars plana vitrectomy was performed. Coming to a summary of the outcomes, we found in case 1, the retina was severely necrotic and friable during vitrectomy. The final visual acuity remained FCCF at 3-month follow-up. In case 2, the PL was lost 2 days post-vitrectomy with subsequent corneal melting. The patient underwent evisceration with eventual socket reconstruction. And in case 3, the visual acuity remained PL-PR post-vitrectomy. The affected eye was found to be thiazical after 3 months. So, what is the discussion? The known causes of pink hypopyon are Klebsiella, herpes simplex zoster, and Serratia. This protegiocin and its synthetic derivatives have been found to have very specific and potent immunosuppressive activity. Serratia infections are most commonly confined to the respiratory tract, urinary tract, surgical site infections, and soft tissues. This red pigment has been identified in keratitis, tooth abscess, and in the urine of urinary tract infection patients. What can be concluded from microbiological assessment of this family is that it responds to aminoglycosides and fluoroquinoline with moderate response to ceftazidime, imipenem, and meropenem. In conclusion, we can state that acute endophthalmitis with pink hypopyon is a rare clinical presentation indeed. Serratia endophthalmitis, as has been quoted in several literature, has extremely poor visual prognosis despite early vitrectomy. In light of the potential severity of ocular involvement by this organism, a characteristic presentation should suggest Serratia marcescens and prompt aggressive as well as adequate therapy. Here are my references, and thank you for your patient hearing.
Good presentation. So all these 3 cases, did they happen on the same day or they are like different
No,
days?
they were in a different timeline. Actually, it was not just 3 cases. We, after the first case, we tried to accumulate cases of pink hypopyon, but as you know, it's probably due to microhyphema in many cases. So we analyzed samples in only the studies where we got positive growth. We have supplied in this case series.
So this was a retrospectively, you looked at the microbiology register and found these 3 cases.
The first case when it happened, we had sent the sample immediately, and after that we sent all cases for the samples, but only the positive cases I have given in this series.
So could you, from these 3 cases, could you give a list of, say, risk factors which could have led to this Serratia infection?
Ma'am, as I have read in literature, this Serratia, it is a nosocomial pathogen, and it is most commonly found in anything that has water in it. So it could be due to our BSS or something else. We did not do a hospital study, that is, we have not taken hospital swabs, so I cannot say from where exactly it has come. But in type 2 diabetes mellitus patients were the most common patients who came with this Serratia marcescens. So we can say that it might be a risk factor, as well as proper sterilization. And since I have not done a hospital swab study, I cannot say from which source the infection has come.
And also the culture sensitivity report for all these 3 patients?
Yes, that was sent to microbiological department. What the microbiology professor told me is that it is found in plants and it is a most common plant pathogen. She asked me, did you have any plant contamination or something in these patients? So none of the patient provided positive history for any plant contamination.
No, I mean, what was the antibiotic sensitivity for these 3 strains?
Antibiotic sensitivity, it was sensitive to fluoroquinolone group in some aminoglycosides like amikacin. Levofloxacin was sensitive in a few patients. Imipenem, meropenem was, it came as moderately sensitive in some of these cases.
Did you check for linolizate?
Linezolid, yes sir, we tried, but there was, I was told that I cannot make 45 drops out of linezolid, so.
We can. I'm interested in what duration it has happened, these 3 cases.
It was over a long time,
wait.
sir.
The second question is that how many cases of cataract surgery or injections or the base for these cases? And third is, you said some endophthalmitis has happened during that period. What is the number of those endophthalmitis where you have not get the positivity?
So there were 3 cases.
Hmm.
I will go from the first question, sir.
Yes.
So your first question was that
The
what
time
was
period.
the time period?
Time period, yes.
I found these 3 cases. I collected these 3 cases over a 2-year period almost.
2 years period. Okay.
Uh,
How many cataract surgeries happened during these 2 years?
Sir, I am
Plus
from
injections, yes.
Sir, I am from AIOC2024. We have
Wherever you are.
I have not calculated the entire list.
You are in
but,
India and you are part of AOS.
The,
The
from
procedure
what I
should
know
be
from my
stringent.
administrative study for 1 year, since I have calculated that list, there were 18,803 operations in total in 1 year duration. So if I can multiply that in a 2 year, it will be 36,000. So out of that, only 3 cases I have got as positive.
No, you said another statement that
Yes,
there
sir.
are several endophthalmitis cases, but this has grown positive. That's why
Yes, sir,
I am presenting.
Sir, the endophthalmitis cases were not all from our department. We have been referred cases.
Achha, these 3 are from your department.
No, 1 case was from referred, sir. The second case which I showed, that was a referred case from outside. The other 2 cases
That
were
clarity
in our
you need
department.
to give in your presentation.
So
That
what
is
sir
number.
is trying to find out, is there any incidence of cluster
Yes,
endophthalmitis?
I've understood,
So
sir.
that's what your timing, time
Yeah.
period, everything is important.
Yes, sir.
And also,
But
are
it
they somehow
was-
related, all the cases?
Yeah, it was not a case of cluster endophthalmitis
And
as
it
far as
appears
I
to be very poor outcome.
Yes, very, very.
What are the reasons for that?
So as I have read that first thing is we cannot detect serratia very early since culture takes at least 48 hours and the organism seems to have a very aggressive role in endophthalmitis. Like I showed in the second case, the patient underwent melting within 2 days. In the third case, possibly I cannot attribute it to that, but possibly the patient was not diabetic and we started her on fortified amikacin having read from previous literature. So maybe her PLPR was and her eye was saved as such, but the visual acuity and the outcome was poor.
Okay, thank you very much. Now we will call upon Dr. Toshit Varshney. His presentation is on staged surgery approach for intractable hemorrhage during diabetic vitrectomy.
Good afternoon, everyone. I'll be talking about staged surgical approach for intractable hemorrhage during diabetic vitrectomy. We have no financial disclosures. So intraoperative bleeding is a major challenge in diabetic vitrectomy and it precludes the membrane peeling on the posterior pole. Even after injecting preoperative bevacizumab, up to 30% of the eyes can have severe intraoperating bleeding, and if the time is delayed for the surgery, it can even lead to VEGF crunch. When bleeding happens, most commonly surgeons use increase in intraoperative pressure, but in diabetic patients we have to be careful because they already have a low mean arterial pressure for the ophthalmic artery, and a prolonged rise in IOP can cause disc pallor. So the objective of the study was to evaluate the outcomes of a staged surgical approach where intraoperative bevacizumab and sulfur hexafluoride tamponade was given for eyes undergoing diabetic vitrectomy for TRD, which were complicated by intractable intraoperative hemorrhage. It was a retrospective case series. Single surgeon cases were taken with an experience of more than 20 years, and eyes with traction retinal detachment, including combined mechanism detachment, were included. So all the eyes which had intractable hemorrhage on table, that is an insufficient hemostasis after multiple attempts of controlling the bleeder, that is by increasing IOP, using endodiathermy or use of PFCL, which led to blood clots that were on the posterior pole and they precluded complete membrane dissection and endolaser. These eyes were closed under 1.25 milligram of 0.05 ml bevacizumab and 2 ml of 100% SF6. On post-op day 15, they were evaluated for presence of retinal detachment, or if there was any dense vitreous hemorrhage along with presence of traction on V-scan. They underwent a second completion surgery where silicone oil injection was done. If this was not present, then these eyes were observed, and if there were any gap areas, they underwent add PRP later on, or break underwent barrage laser. Outcomes that were assessed were absolute success, that is the retina was attached without any tamponade. Relative success for complete retinal attachment under silicone oil tamponade. So in the period of 2 years, 980 eyes underwent surgery, out of which around 165, that is roughly 20% of eyes, had this intractable hemorrhage. At baseline, the key features that were significant were that these up to 42% of eyes had bilateral severe visual impairment. The most common systemic comorbidity was hypertension. Anemia was present in 57% of eyes, and the median baseline HbA1c level was 10. So after the first surgery, 43 eyes they didn't require a second stage surgery. Their best corrected visual acuity was 0.6 logMAR, and out of them, 9 eyes required add PRP, 11 eyes required barrage. 2 eyes had a rebleed for which they required repeat silicone oil injection. The factors that were associated with requirement for second stage surgery significantly were lower age at presentation, higher duration of symptoms, and involvement of macula, that is MTRDs and combined mechanism RDs. After second stage surgery, the final best corrected visual acuity was roughly 6/60 in these eyes. Absolute success was seen in 68% of the eyes. Relative success was in 17% of the eyes. Failure rate was 14.5%, and 12% of eyes had neovascular glaucoma. So factors that were associated with a good visual outcomes were lower duration of symptoms, better baseline visual acuity, lower diastolic blood pressure. This is a perioperative blood pressure, and less number of MTRDs and combined mechanism RDs. On a multifactorial analysis and subgroup analysis, it was seen that duration of symptoms was the most consistent, most significant factor. So these are few representative images. Coming on to a discussion, compared to the national study that has been done, the patient in our group had a lower age at presentation. The hypertension was significantly the most common systemic comorbidity, and baseline HbA1c was high. Anemia has previously been seen to cause increased bleeding tendencies, but it has not been evaluated in a study with DR yet. Perioperative blood pressure, to the only study that has been previously done in DR eyes, our perioperative blood pressure was higher, but we can't compare these two studies as such. And these were the factors that have been seen in previous studies which affect the visual outcome and compared to our study. So limitations was it was a retrospective study and it was non-comparative. Coming to conclusion, we are saying that this is a safe approach for such eyes, and it is a viable alternative and not the main line. When there is intractable hemorrhage, we can proceed with something like this. Thank you.
Good presentation. Can I ask you what is the rationale for putting that 100% SF6 on table in this vitrectomized eye?
Ma'am, I'll answer this in two parts. So previously, what has been mentioned in textbooks, especially Ryan's, where it says that more than 1.2 ml of pure SF6 should not be injected in the eye. That has been based on a study that was done in 1979 and 1985. Both those studies were done on rabbit eyes, and it was not a human study. Compared to that, recently we have already published a paper that I mentioned as a reference, where 75 eyes for macular hole, at the end of the surgery, we injected 2 ml of pure SF6 instead of the usual 18% concentration that we take, and none of these eyes had any complication. So as a part of our protocol in our institution, we usually inject 2 ml of 100% SF6. Also recently in 2018, a paper has been published in Ophthalmology Retina, where they have prepared eye models for human eye comparing different axial lengths, where they have found that if almost we inject till 50% of the vitreous cavity volume is injected with the pure SF6, it won't cause subsequent high rise in IOP. And when we are injecting 2 ml of SF6, we are also opening the infusion port. So it roughly comes out to somewhere around 40 to 45% of the vitreous cavity that is occupied by this SF6.
So this is injected in a fluid filled cavity or in an air filled cavity?
Air filled cavity, ma'am.
Air filled cavity.
Yes.
Okay. So the main thing is, if you are looking at this perioperative bleeding, your main intention of injecting gas or air is actually hemostasis. So you need an immediate pressure, increased pressure in the eye for hemostasis. So I don't know whether this, of course, if you are already done air FGE, that will give enough pressure. So whether gas should be injected or not, that also in a surgery where the membrane dissection is inadequate, which carries a risk of developing iatrogenic breaks, because if there is already a break and the membranes are not completely removed, then you are putting the patient at a risk of developing further breaks.
Ma'am, the rationale for this was that a lot of cases before starting the study had bleed under the silicone oil, which required oil removal followed by again injection, and a very high intraoperative post-op IOP. So nothing like that was observed in this study. Another use for this was that sometimes the clots, usually they disappear by 2 to 3 months, but sometimes they act as a nidus for repeat fibrovascular proliferation and causing again detachment. So that thing was taken care of. And also at 15 days when there was a redetachment, these cases were taken for a resurgery, and that time the bleeding was not significant and they could be closed in the second surgery.
What is your premise of using gas and anti-VEGF post-vitrectomy?
Sir, one of the premises that in our institution there is no protocol of injecting preoperative bevacizumab in the eyes, because a lot of these patients are systemically unstable and they are not admitted for those 5 days that we inject, and they are admitted for 3 days and then they undergo surgery. So that is not done. So we inject bevacizumab on table so that post-op complication, post-op the membranes, the bleeding is less.
Is your study design will support your premise?
Yes, sir.
Is your study design support your premise to test your person or whatever you are thinking? Is it sufficient enough?
Sir, the other thing, according to a design, we should have a comparative arm, that eyes that didn't undergo second stage, that didn't have intractable hemorrhage, they should be compared. That is one of the limitations. That data collection is
Not
under
limitation. This is the
Yes, sir.
design that need to be
Yes, sir.
tested in your study.
Yes.
So I want to ask you, bevacizumab was injected in all the 165 eyes,
Yes, sir.
despite them being, you're telling, I mean, so this whole study is based on preoperative non-injection of bevacizumab to these patients, predispose these patients to higher risk of bleeding, which is 165 out of 980, which is fairly high, and that is why you required a 2-stage surgery. So I would say, I mean, there is a lack of design probably here. I would say that the reason for the bleed is, you have not injected them with preoperative, preoperative bevacizumab, which is now almost a standard in all these cases.
So to answer that question, so the second premise for the study was that when there is a lot of intraoperative bleeding and we are again and again increasing the IOP, we get a 100% anatomical outcome, but the disc has pallor in the postoperative period.
No,
The
that
other
would be
thing
there
is
in
we
this
have-
case or the other
Yes, sir.
case.
And we have conducted a smaller study in our institute, which I have not presented the data here, where 15 eyes that underwent 2-stage surgery, they were given preoperative bevacizumab and they still develop intractable hemorrhage. I've also put a reference that up till 30% of eyes can still develop severe bleeding, and this was a 17%, 980 divided by 165, it is somewhere around 17%. It's still less than what has been published in literature. So out of those 15 eyes that had been given bevacizumab and still required second stage surgery, so that showed the patient profile has other risk factors which is predisposing them to bleeding on table.
Okay.
Just one question. For those 165 cases, do you have data for those number of patients who had residual traction at the time of bleeding?
Yes, sir.
So, because if you compare the outcome, final outcome of the second stage surgery, some patients you told it cleared on their own. So, those who have residual tractions at the end of the surgery when the bleeding had happened, those are the ones which are supposed to have
Yes, sir.
poorer outcome and requires a second surgery.
Yes, sir.
So, do we have a data? Of
Yes,
that
sir. We
as
have.
well? So,
we
probably
have.
you can compare
Yes, sir.
that also. That will be more meaningful. Thank you.
Thank you, sir.
Thank you very much.
Thank you.
Now, can I call upon Sweta Singh? She will be presenting an ISA or the windows to the soul, chronic CSR as the presentation of pituitary tumor.
Good afternoon, everyone. My topic for today's is eyes are the window to the soul. So this is a case of a 50-year-old female who presented to us with gradual progressive diminution of vision in both eyes for the past 5 years. She had associated metamorphopsia. She was fairly controlled diabetic and hypertensive and was diagnosed as bilateral CSCR elsewhere. There was history of use of topical NSAIDs, dorzolamide and tablet eplerenone. The history of focal argon laser was done twice elsewhere, There was no history of any corticosteroid use, so they labeled it as therapy-resistant chronic CSR. On anterior segment examination, the best corrective visual acuity was 6/12 in both the eyes, and rest of the anterior segment was within normal limits. But in posterior segment, the fundus of right eye showed significant RPE changes at the posterior pole, along with some mild to moderate changes of diabetic retinopathy. In left eye, the media was quite hazy due to asteroid hyalosis, but we could still detect some RPE changes at the posterior pole itself. OCT showed in both eyes shallow SRF, which was suggestive of chronic CSR, along with loss of ISOS junction. On OCTA, we could not detect any choroidal neovascular membrane in either of the eyes. On FFE, we could detect some window defects, which were a sign of previous focal laser done. Ink blot pattern was also seen very close to fovea, which was not laserable. That was in the same, that same thing was also detected in the left eye. Now, typically, a CSR presents as a unilateral condition in young middle-aged males, and it is self-resolving. But CSR in an old-age female, bilateral presentation, and recalcitrant was something different, and we were sure that we were missing something. So we went retrospectively and analyzed her history. She had easy fatigability and mood swings, truncal obesity, thinning of upper limbs, rounding of faces, and she had a peculiar history of growth of unwanted dark hairs on face and trunk, for which she had even underwent laser hair removal twice in past. She suffered multiple fractures in past few years. So we came to the conclusion that there was some hormonal dysfunction, and we advised for an endocrinologist review. From our side, we gave topical NSAIDs and lubricating eye drops. So for the first time, she underwent a biochemical evaluation and was diagnosed of ACTH-dependent Cushing syndrome, and pituitary was seen as a source, which was detected on the gold standard inferior petrosal sinus sampling. All was done under endocrinologist. MRI pituitary dynamic contrast also revealed a small pituitary tissue. So, with a neurosurgery opinion, she underwent exploration of the sella, and a pituitary tumor was resected. It was identified as microadenoma, and the next day itself, her cortisol levels dropped from 35 to around 3, which was quite significant. After 1 month of follow-up, we could see that there was complete resolution of SRF, and vision acuity improved from 612 to 69. Although there was some RP degenerative changes and ISOS junction loss, which contributed to decreased vision. The same was detected in the left eye also. Patient has been on regular follow-up for the past 1 year. Her vision improved and metamorphopsia has significantly reduced. She consults with endocrinologist and neurosurgeon regularly. There was no recurrence of CSR reported during this period, and there was no recurrence of any of the pituitary tumor. Now, hypercortisolism is a known risk factor for chronic CSR. Patients with chronic CSR had a higher odds of Cushing syndrome than exposure to exogenous steroids. The blood cortisol excess, this leads to vasospasm in the choroidal vasculature, which leads to choroidal ischemia and hyperpermeability, which in the end leads to the deposition or accumulation of SRF in the, between the neurosensory retina and the RP. It is a multifactorial disease, and localized serous retinal detachment at macula is the characteristic. We can see focal PEDs, and typically affects middle-aged men, although women can also be affected. Acute CSR has been categorized as spontaneous resolution within 4 months, but chronic is termed whenever it persists for more than 4 months. It carries a guarded visual prognosis due to atrophy of photoreceptors and RP. Associated risk factors include the triple S, that is stress, steroids, and smoking. So one should advise and advocate against it. And currently, this has been categorized under pachychoroid spectrum, in which there is hyperpermeability of the choroid. Management currently involves observation, lifestyle modification. We, in our patient, have checked on steroids. So that was a major management in our case. So there have been published literature which has shown an association, a positive association between Cushing syndrome and...
time is up.
Sorry, sir. Just last thing. Okay. So this is one of the study which I would like to discuss, in which they have analyzed a large cohort of CSR patients, around 35, and they showed that none of them had any Cushing syndrome phenotypes. So they have advised against screening of Cushing syndrome in CSR patients. So take-home message that it is a clinical diagnosis. Lifestyle modification is the key. Not every patient of CSR needs to be screened for Cushing, and patients of Cushing need an ophthalmological workup only if the ophthalmic symptoms arise. Also, in cases of atypical presentation, think out of the box. Thank you.
So that was really interesting, and I think I must say congratulations to you for picking up this pituitary tumor just from the CSCR. One thing I would like to ask you is, how long did this patient use eplerenone, and why do you think that patient did not respond to eplerenone? Because eplerenone is a mineralocorticoid antagonist. Patient has some inherent cortisol, high cortisol. The eplerenone should have, counteracted that. So why do you think it did not work?
Ma'am, because due to her continuous hypercortisolism, because of high cortisol levels in the blood, which remain for a longer period of time, there was dysfunction at the RP level, and there were continuous hyperpermeability at the choroid level. So even eplerenone was not that effective. Also, one should not keep a patient on eplerenone for a long time because it can lead to fluctuations and decrease in blood pressure. So we had to maintain blood pressure and the kidney profile of the patient also. So that's why.
How long was that eplerenone given?
Ma'am, when patient presented to us, she was on eplerenone for a month, but she was not showing much resolution of SRF. So, looking at the phenotype of the patient, we advised for an endocrine evaluation.
I think another thing would be the time, the diurnal variation of the cortisol, because the cortisol is secreted highest in the morning. So when this eplerenone is given, at what time the patient took eplerenone also would be effective. I mean, would be of importance in this case.
Okay, ma'am, we'll take care. Thank you.
Excuse me. How did you suspect pituitary tumor in these patients, in your patients?
Sir, just she was showing to us multiple times. She was coming to us in regular follow-ups. And
Can you turn on the mic, the other mic? That was not working.
Hello?
Yeah.
Okay. So she was on a regular follow-up, and just after looking at the patient, she had round faces, she was always depressed, she was even taking some medication, she was on and off medication of depression. So just looking at the history of the patient, we gave a chance of evaluating for endocrine, and it was a good decision from our side also that for the first time she underwent.
What evaluation was done endocrine?
What evaluation was done?
Yeah.
Serum cortisol levels were done, and the high dose dexamethasone suppression test was done. We had for detecting whether it was adrenal source or pituitary source.
So clinically you didn't suspect. Only after seeing cortisol you sent for a neurological evaluation.
Yes, we did the basic from our side and then sent for an.
And in your study, you said proposed pachychoroid spectrum. Yes. Did you analyze the choroidal thickness in your cases?
No, sir. We had the OCD but not the EDI, so we couldn't actually.
No, whenever you are talking about it, it's better to include in your study before talking.
Okay, sir. Will be taken next week. Thank you.
Thank you very much.
Pigmented? Was the patient having hyperpigmentation?
Easy bruising, yes.
Not easy bruising, hyperpigmentation.
Of the skin.
Of the skin?
Yes. That's around the neck, and
yeah,
she had those changes.
That is a clinical indicator that ACTH level is high.
Okay, sir.
In the flexures,
fractures, multiple fractures, and different other cortisol phenotypes. Okay.
That you have not presented in the cases.
Sorry, sir?
That you have not presented in your presentation. So everything we cannot take it as right. Okay. Thank you very much.
Thank you.
And now we will go on to the next speaker, next presenter, Dr. Nibha Mishra. She will be presenting as advanced glycation end products or biomoleculars as biomarkers of PDR, right? Okay.
Good afternoon to one and all. Today I will be presenting my research titled Advanced Glycation End Products are the Biomolecular Biomarkers of Proliferative Diabetic Retinopathy. Diabetic retinopathy, as we all know, is a major neurovascular complication of diabetes mellitus. And we live in a world where diabetic retinopathy, diabetes mellitus has become an epidemic. So day to day, we are fighting and finding ways to get rid of this vision impairing, especially the functional group of population. Coming down to the pathogenesis, because we want to know the each step, hyperglycemia. One thing which has been now more studied is what is happening after hyperglycemia, what is triggering all the things. So there is a non-enzymatic glycation reaction which affects proteins, lipids, nucleic acids, resulting in formation of advanced glycation end products. The molecule I am concerned about is N-carboxymethyl lysine, which I have studied in my research, is one of the most common one. It results in irreversible damage to the structural and functional integrity of all the three skeletals of our body structure, that is proteins, lipids, and nucleic acids. Where comes the main concept of metabolic memory, that is the irreversible damage. Why metabolic memory? Because even if the hyperglycemia is reversed, the effect remains. So the objective of our study is to study the role of ages as a biomolecular biomarker for proliferative diabetic retinopathy, because that is the vision-threatening one. So we included consecutive ophthalmologically naive patients of type 2 diabetes mellitus ranging from 40 to 65 years of age. Based on our clinical evaluation, divided them into 3 groups, no diabetic retinopathy, NPDR, PDR, and age and sex match volunteers were taken. Now what were our exclusion criteria? Any condition where the vascular, already the retinal vascular pathology pre-existed, we did not include that. It was treatment naive patients, and the conditions where the NCML levels can be high, like Alzheimer's and pulmonary fibrosis, they were not included. So we did a detailed data collection of the demographic details. We took the BCVA and did the thorough fundus examination. Blood investigation included the glycemic status by fasting and postprandial blood sugar. HbA1c levels were taken, and assay of NCML was done by quantitative sandwich enzyme immunoassay technique. The main thing which we did was the ROC curve analysis, and through that we found out the area under curve. The power of our study was 94%. Quickly walking through the results, all the groups were age and sex matched, but what we noticed here, if we notice, is NPDR and PDR, they have a similar study duration, diabetes duration, that is matching. There is no difference, and the logMAR visual acuity is declining as the severity of the disease is increasing. But the N-carboxymethyl lysine, if we do a ANOVA analysis, there is a significant difference between all the groups. What is also noticeable is in NPDR and PDR groups, the fasting blood sugar, the postprandial blood sugar level, and HbA1c levels are almost equal. That means that they are not indicating truly the condition of the disease. So we did the AUC analysis and found that the area under curve for PDR was 0.84. As we can see, there is a horizontal line in this. The y-axis is the sensitivity, and the x-axis is the 1 minus specificity, what is shown in the ROC curve. And the more it is towards the y-axis, that means more the sensitive and better diagnostic tool which we are aiming for. And we can see the blue line is for the PDR, and it is 0.842, which is quite good. So the age-range axis leads to a continued cellular dysfunction. Age is called retinal parasite apoptosis. In fact, it is said that they are the triggering agents for every pathological phenomena occurring, oxidative stress. That is why they have also become the new therapy targeted along with the oral hypoglycemics, antihypertensives, and insulins. So why not HbA1c? Why we are moving toward a good, better molecule? Because as I say, they sometimes don't represent the actual condition. They are chemically modified, there can be anemia, there can be many things where HbA1c fails. So ages are the major biomolecular biomarkers for pathophysiology of evolution of diabetic retinopathy. They are novel therapeutic targets, and they are the new age tools of translational medicine. Thank you.
Very good presentation.
Thank you so much, sir.
So I just want to ask, usually a person progresses from no diabetic retinopathy to non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. And as we all know, age products occur in the first time when hyperglycemia occurs.
Yes.
So age products continue to get accumulated. And probably the duration, even though the duration of diabetes that we take is a very, not a very sacrosanct thing, because it's what the patient says.
Yes.
So is it possible that the proliferative diabetic retinopathy had been long-standing, and that is why the age products are higher in those,
So that
despite having similar durations?
Yeah. So that can be a scenario here. That in fact that is the basis of my study also, which I want to state that sometimes, many times in our OPD we get patients, we are saying that we have reached a PDR stage, you are saying, but our blood sugars have been controlled for so many times. They show us a very good HbA1c levels. But that are the false markers. We want to tell them that even the reversal of hyperglycemia is not an indicative of an already done damage. So this presents a true picture to them. So see, this is a long duration. So as you said, sir, the long duration is already affected on biomolecular level.
I'm asking that, you said it's a marker for PDR.
Yes, sir.
Till now, we are thinking that it's a marker for long-term hyperglycemia.
Yes, sir.
Right.
Yes.
So,
So that is what I've tried to show in this also, that the two groups, and I said also, the NPDR and PDR had a comparable duration of disease.
that is
that
now.
was 10 years.
That is now. But
Yes.
age is dependent upon the last 20 years of diabetes, right?
Yes, sir.
Yeah.
Yes.
So now the hemoglobin A1C will not give us that much understanding,
Yes,
right?
that's what I'm trying
So
to
that is
say.
a limitation.
Yes.
Yeah. Okay.
Thank you so much.
Between the presentations, we have two keynote speakers. We thought they should be presenting first, actually. So, is Dr. Purnachandra here? Yeah. Can you tell them to project your presentation so that he is keynote speaker for Dr. S. Natarajan Award. His topic is novel genotype phenotype correlation and exploring potentials for gene therapy in Stargardt's disease. Dr. Purnachandra.
Thank you so much. Thank you, AOS, for giving me this opportunity.
Yeah, the marks will not be there for these two keynote speakers. You don't mind, I think. Okay.
So I presented this work last year. Over 1 year, there are some updates also which I presented recently in VRSA also. I thought I would take this opportunity to give an update on what was happening last year and what is something new which we have found. So as we all know, Stargardt disease is originally described by Carl Stargardt's most common juvenile macular degeneration due to ABCA4 mutation, and 95% of Stargardts are due to ABCA4 mutation. The genetics of ABCA4 revolves around a transport protein which is involved in accelerating the removal of all trans-retinaldehyde. So this is the final pathway. Whenever there is a defective ABCA4 mechanism, there will be excess accumulation of lipofuscin and other byproducts, which the RP cells and the other cells fails to digest, resulting in apoptosis and disease manifestation. Purpose of our study was to report novel phenotypic pattern genotypes in Indian cohort. This was an observational study. So this was the roadmap for our study: identifying families with Stargardt disease, identify and isolate the mutation, studying this mutation in cell lines, how to repair this mutation, and how to monitor the repair. So our study cohort had 39 families, so among which we used whole exome sequencing to identify and isolate the mutation. So all patients, as I told, underwent detailed examination, and electrophysiological tests were done wherever it was required. So coming to the results, the age ranged between 9 to 64 years with a mean of 24 years. The consanguinity was present in 28 out of 39 families, that is almost 75%. So a spectrum of fundus abnormalities was detected. This was a 28-year-old male with a typical Stargardt-like phenotype. This patient had homozygous mutation ABCA4 gene. The second one is a 30-year-old female, also had Stargardt's ABCA4 mutation, but there was only atrophic macular changes and no flex at all. So this was one more 46-year-old male with an extensive degeneration involving macula and also the mid-periphery, and along with that there was kind of an outer retinal cavitations in one eye, which possibly could be related to an associated myopia. So this was an interesting family where the daughter, being younger, was symptomatic with the Stargardt disease, fundus tissue of foveal atrophy. So this patient had compound heterozygous mutation ABCA4, that is 2 mutations and a different location of the same gene. Mother was asymptomatic, was homozygous for one of those mutations. When we examined the mother, fundus was absolutely normal. However, the autofluorescence and OCT did show some perifoveolar changes. So this is the typical example for same disease, same gene, same family, but depending on the inheritance pattern and the mutation pattern, the disease severity and progression could be different. So this was one more case of 43-year-old female was diagnosed as Stargardt's elsewhere. So she had a family history of father having some retinal problem. When we screened, the father had atrophic macular changes and maybe resolving flex in the perimacular regions. So we ended up finding out a gene called SERPINF1, which has never been reported in the literature. But the interesting fact was the children who were totally asymptomatic were also carrying the same mutation. So when you screen the children, the fundus was absolutely normal, OCT was near normal. But if you look at the autofluorescence, definitely there is an abnormal autofluorescence in the macular region. So this is the OCT and autofluorescence across 3 generations with increasing grade of severity. So most of the mutations in our cohort was missense mutation. Among these, 7 were novel mutations. We wanted to do an in vitro study in this thing, which is a recent update. So to study the effect of this mutation, what we used was a HAK cell lines, and we used Western blot analysis for the protein function. So to make it simple for understanding, this is the control. So these are the different mutations of ABCA4. The darker the band, better is the protein function. So for example, the proband is a 13-year-old male with a relatively good vision of 6/12. This patient has V type of mutation. That means relatively better protein function. So the phenotype is also less severe. As compared to the 9-year-old who is 4 years younger, but the disease is more severe because this patient has a Q type of mutation. All are same ABCA4 mutation, but depending on the protein expression, severity could be different. So the ERG was also telling the same story. In the first patient, fulfilled ERG is almost near normal. In the second, there is a diffuse dysfunction indicating a rod cone dystrophy type of phenotype. So on how to repair this mutation? So there are some challenges when it comes to larger genes like ABCA4, USHA2, because this cannot be loaded into the single vectors because the cargo capacity is limited. So we came up with a novel dual vector strategy where we split the gene into 2 halves, loaded into the separate variants, and once they were co-infected together, they reach the target site where they are intended to produce the expected proteins. So these are the histological studies which we are doing last time. Now we have come to a stage where we are doing the live ERG in the live animals. So if you look at the control, the intact vector, and the animals which received our dual vector, the staining pattern is almost comparable. So our vectors are reaching the intended site.
One more minute for you.
Yeah. So what was known as this is how a Stargardt disease looked like with atrophic macula and the typical flex and outer retinal loss and the OCT. What our study adds is we demonstrated genetic sequencing and screening of Stargardts in Indian families, presence of new genetic and phenotypic variations, and experimental models for pathogenicity of mutation, and animal models to study the dual vector for gene therapy of Stargardt disease. These are our ongoing projects. So this is the wild type mice, that means the mice with a normal ABCA4 function. This is the mice with ABCA4 knockout. So this is a recent update. If you look at the lipofuscin pattern, this excess lipofuscin accumulation. So once we give the injection, the lipofuscin will start dissolving. So we managed to do ERG in these mice. If you look at the mice which received our dual vector as compared to the control and non-injected vector, definitely there is improvement in both A wave and B wave amplitude, indicating both restoration of inner and outer retinal integrity. So our future plan is obviously to start human trial. Hopefully next year I will be presenting that data. Thank you so much.
Thank you very much. And is Dr. Chintan is here? Chintan Desai? She's not there. Okay. Then we will move on to Dr. Kaushik Dan. Shauvik Dan. Shauvik Dan? Yeah. His paper is mainly the unexpected full thickness macular hole formation following intravitreal ranibizumab injection in RVO, a case series.
Hello everyone, I am Dr. Shauvik Dan, and the topic is full thickness macular hole formation after intravitreal injection of ranibizumab and ranibizumab biosimilars in retinal vein occlusion, a case series. We all know anti-VEGF therapy, particularly ranibizumab, have shown efficacy to reducing the macular edema and improving the visual acuity in RVO patient. And the biosimilar agents actually offers a cost-effective alternative to the management of the retinal vein occlusion. There is a paucity of the literature regarding the potential unique complication, and full thickness macular hole after the anti-VEGF therapy is a occasionally reported complication whose pathogenesis is remain poorly understood. Aims and objectives are to discuss the potential pathophysiological mechanism, highlight the importance of the patient selection, consider the implication of, for clinical practices, necessity for careful monitoring of the patient receiving anti-VEGF therapy, and provides the insight into management of this rare complication. Methods. The series actually involving 5 patients who are with RVO had developed full thickness macular hole subsequent to the injection of the ranibizumab and its biosimilars. Actually, the cases highlights the varying presentation, management strategies, and outcome. And the treatment approaches are actually observation, pars plana vitrectomy with internal limiting peeling, and gas or silicone oil tamponade and intravitreal DEX implant. Studies site Dishai Hospital, Barakpur. Study duration 4 weeks to 4 months, and ages are actually 59 to 72 years age, male-female ratio 2:3, and primary outcome is a BCVA. These are the case summaries. Case 1, it is a 67 years female, base corrected visual acuity 6/18, presented with a hemi-CRVO. I injected ranibizumab biosimilars, and after 4 weeks, the patient developed full thickness macular hole. The primary management were vitrectomy, internal limiting membrane peeling, and followed by SF6 injection. The hole was closed after the primary surgery, but the CME doesn't resolve. So I implant one dexamethasone implant, and followed by another dexamethasone implant after 4 months, because the CME is not reducing, and ultimately the patient improved the visual acuity 6/9. Second case, it is a 72 years male, 6/18, present with BRVO, received 2 ranibizumab. After 3 months, same type of presentation and same type of management was given. And the third case, it is a case of CRVO. Here he's actually injected 2 ranibizumab biosimilars. After 80 weeks, the full thickness macular hole developed, and here we inject 1 dexamethasone implant. The fourth case, actually spontaneous closure happened because the hole is too much small. And the last case, we need to inject the silicone oil tamponade to close the macular hole surgery. This is some pictures of the cases. You can see some amount of VMT and CME in cases, and after injecting ranibizumab, there is a full thickness macular hole, and is after the surgery. So discussion part, intravitreal injection of ranibizumab actually inhibits the anti-VEGF-A. The protein induces vascular permeability and angiogenesis, thus playing a pivotal role. Biosimilars are actually subtle differences in post-translational modifications occur, and they actually theoretically influences their safety profile. Rigorous post-marketing surveillance and reporting to detect the rare adverse event, and the full thickness macular hole formation is rare but a serious event. So the pathophysiological mechanism not entirely clear. There is 3 mechanisms: sudden release of the vitreomacular traction secondary to the rapid resolution of the macular edema, some mechanical damage by injection, and some inflammatory mediators leading to the tractional force to the macula. Discussion, there is a paucity of the literature, as already said, and actually the mainstream of treatment is PPV, and spontaneous resolutions are rare. Actually the prognosis depend on the chronicity of the hole, size and stage of the hole, presence of any concurrent ocular pathology, and the timing of surgical intervention. So conclusion, full thickness macular formation is a rare but serious complication, require prompt recognition and appropriate management. And further research, including post-marketing surveillance, is necessary to illustrate the full spectrum of the safety and efficacy of the biosimilars. As the use of the anti-VEGF therapy continue to expand, ongoing surveillance and reporting in better understanding and managing these complex cases. These are the references. Thank you.
So what is the pathomechanism behind the injection and macular hole?
Sir, I think some amount of vitreomacular traction is present in all cases. That should have been considered.
Aggravation of that traction is the cause for hole formation?
There is a sudden release of the traction when the reduction of the cystoid macular edema, that can cause the hole formation.
How do you prevent that?
Sir, actually, we should actually do something else like subtenon Kenagott injection or dexamethasone implant in such cases.
That is your recommendation of this study.
So you mean to say that the biosimilars have a more rapider resolution of fluid and thereby change in tractional lines as compared to the innovator?
I don't know actually, sir, but that may be the reason.
No, when the edema reduces,
Yeah.
will the traction not reduce?
Traction is always reduced. Because of the traction, the macular hole was formed. And after the internal limiting membrane peeling, there was some edema. I was injected Dex implant to reduce that edema.
You have not mentioned what was the pre-operative, the macular edema, how much was the thickness of the retina, whether it was ischemic, non-ischemic, and third thing is whether the PVD was present when you did the macular hole surgery, whether the PVD was there or no. So these three things I think are important.
Okay, ma'am. Noted.
Dr. Ananya Goswami. Her study is surgical outcomes in pediatric rhegmatogenous retinal detachment, a comparative study.
Good afternoon, everyone. I'll be presenting on the surgical outcomes in pediatric rhegmatogenous retinal detachment. The slide is not moving. Pediatric retinal detachments are relatively less common compared to adult RDs. The complex etiology is a challenge for surgical management and has a poorer prognosis. The purpose of our study is to look at the anatomical and functional outcome of this pediatric rhegmatogenous retinal detachment in a tertiary care center. There is paucity of literature regarding the same in the Indian subcontinent, and this is one of the first study to compare the various techniques of pars plana vitrectomy, especially the role of short-term perfluorocarbon tamponade. It was a retrospective comparative case series. The primary outcome of our study was to look at the corrected distance visual acuity, and the secondary outcome is to look at the success and the associated complications. All cases of rhegmatogenous RD less than 18 years were included. Tractional RD and exudative RDs were included. Also, the cases who had undergone previous VR surgery were excluded. 288 eyes of 270 patients were recruited, and the following parameters were noted. The patients underwent either of the following surgery as per surgeon's discretion: conventional scleral buckling or pars plana vitrectomy with silicone oil tamponade. Along with that, encerclage of 42 band and pars plana vitrectomy and silicone oil tamponade, and pars plana vitrectomy along with short-term PFCL tamponade for 3 to 4 days, followed by PFCL removal and silicone oil tamponade. The outcomes of the PPVs were defined as absolute success where the retina was attached without any tamponade, relative success when the retina was attached with tamponade or there was peripheral detachment with attached macula without any tamponade. Failure was defined as detached retina under tamponade, and for scleral buckle it was defined as detached retina at 6 months. Coming to the results, the mean age was 12.6 years, 83% were male, the baseline visual acuity was 2 logmar, 15% has systemic association. Most common etiology was trauma, closed globe injury comprising of nearly 25%. 34% had subtotal RD, out of which 45% had macula on. Incomplete PVD was seen in 93.4%, choroidal detachment in nearly 18%, 21.5% had more than one break, and PVR changes more than C were seen in 44%. Most common type of break noted was retinal hole. Moving on to the outcomes at 24 months, the overall success was 77%, while comparing the failure based on the age less than 12 years and more than 12 years, it was comparable. The visual acuity had improved from 2 to 1.5 logmar at 24 months, which was statistically significant. Moving on to the group-wise analysis, in scleral buckle, the success was 71%. Comparing the various techniques of pars plana vitrectomy, the age and the preoperative visual acuity was comparable. In the PPV PFCL group, the PVR changes were seen in nearly 75%, and none of them had macula on RD. The final visual acuity in all the three groups were comparable. The success, overall success in the groups PPV was 71.4, PPV PFCL was 69%, and the PPV encerclage was 91%. However, in the encerclage group, for nearly 49% had to undergo resurgery. The complications noted were secondary glaucoma in 27.4% and corneal decompensation in 5.5%. The incidence of rhegmatogenous RD in childhood is 1.5 to 5.9%. Most common cause is trauma, which is similar to our study where 40% had cause as trauma. Closed globe is more common. The choice of surgery is as conventional, where vitrectomy was performed due to poor visibility of the fundus and break when it's not localized, and in cases of advanced PVR. PVR is more frequent in children, because of delayed diagnosis and high intraocular cellular activity. 41.1% in our study had PVR more than C. Out of the 9 eyes were closed funnel RD, which were in the PFCL PPV group. PPV endotamponade as a short-term endotamponade has been safe and effective and is safe up to 5 weeks. In adult rhegmatogenous detachment, the success is around 92%. However, there are no studies about the same in pediatric population. This is already discussed. To conclude, this study shows a high anatomical success along with significant functional improvement following surgical intervention for RRD in the pediatric age group. PVR-C shows a poorer prognosis. Overall success in all the techniques were comparable. However, in PVPFCL group, it's more beneficial in those with advanced disease. Thank you.
This is a good analysis, but I feel that clubbing all cases like traumatic or just a simple rhegmatogenous and also the syndromic cases, that is FEVR and juvenile X-linked retinoschisis, is a bit of I don't think it is correct, because you see the syndromic patient, the FEVR and the juvenile retinoschisis will have much more vitreoretinal adhesions and much more problems. So the success rate we know in these cases is all low. So vis-a-vis, if you look at just a simple rhegmatogenous RD in a child or say traumatic RD, the success rate will be higher. So I think that is, you need to look at your preoperative characteristics of these patients, and you need to also do some subgroup analysis based on that.
Thank you very much. We'll now move to the next presenter, Dr. Parvez Khan. He will be presenting suprachoroidal PRP injections, an innovative approach in management of retinitis pigmentosa.
Good afternoon, everybody. As we all know, RP is a group of hereditary retinal dystrophy characterized by severe vision loss. This first starts with night blindness, that it progresses to complete blindness over the period of time. So, coming to the...
you can be a little closer to the microphone, please.
The other mic.
This one. Coming to the pathogenesis, it has been postulated that decrease in the growth factor levels in the photoreceptor microenvironment is implicated as a cause of apoptosis and cell death. Not all photoreceptors die at once. Some die, while some others, because of the harsh environment, go into the G0 phase. It is hypothesized that introduction of growth factors can significantly slow retinal, not only significantly slow the retinal degeneration cell death, but also reverts back cells from G0 phase back into active cell replication. So, as the apoptosis is going on, there is a loss of signal output from the sensory rods and cones to the neural retina, and bipolar cells, and that leads to a phenomena called deafferentiation of neural retina, and that leads to some phenomena called remodeling at the cellular level, which is characterized into phase 1, 2, and 3, and reprogramming at the molecular level, that is the rod bipolar cells, which is converted from on rod bipolar cells to off rod bipolar cells. The graph which we see in the multifocal ERG is the activity which is shown by the bipolar cells. So when the bipolar cells become diseased, the graph which we see becomes distorted. So why we reached for PRP? PRP, as we know, is a rich factor for certain growth factors like PDGF alpha-alpha, beta-beta, alpha-beta, transforming growth factor beta-1, beta-2, VEGF, BDNF, and epithelial growth factor. As well as it has got molecules like fibrin and fibronectin, which serve as connective tissue constituents to help epithelial migration and adhesion. Hence, PRP was chosen for this study. As we know, autologous PRP was chosen, and it's the best part of this is it's free from the transmission-related risk factors. The reason it has been why we chose PRP, because it has already been used for many things like for musculoskeletal disease like hair regrowth therapy, in wound healing, in graft survival, in oral maxillary surgery. So we chose two routes. First was the suprachoroidal route, which I used my own indigenously designed needle to inject PRP, and the rest subtenons used, which was act as a depot preparation. This is the needle which I have used, for which I already got a patent. There were four parameters which were assessed. First was the visual acuity by TDR chart was noted before each injection and were followed till 6 weeks from first injection. Then multifocal ERG was done pre and post 6 weeks. Then OCT was done and perimetry was done. Though no significant changes was seen in OCT and perimetry, but for the first time in this particular disease, RP, improvement in the visual acuity and was noted, which was corroborated by the multifocal ERG response. Namely, there was change in waveform from abnormal to trending towards normal in trace array graph of multifocal ERG. Strength of response increase in heat map in multifocal ERG. Significant increase in the amplitude density in all the three rings, namely for N1P1 and N2P2. And in those cases where there was no amplitude density seen in pre-intervention, there was occurrence of amplitude density started appearing post-intervention. This is the logmar visual acuity chart, which as we can see, it's significant. This is the amplitude density chart between the control eye and the intervention eye. This is again the graph showing this. As you can see, the right eye, you see the heat maps. If you compare from the right side to the left side, the heat map becomes lighter. Lighter means a stronger response. So we see that reappearance of near normal waveform and improved signal strength in multifocal ERG indicates growth factors derived from PRP have led to activation of the diseased bipolar cells, either by interfering in reprogramming or remodeling of the bipolar and photoreceptor cells respectively. Though we understand it's a genetic disease, so gene therapy is the permanent cure, should be the permanent cure, but with 240 genes in play, it seems a distant reality. Just a small...
Time is up, you need to cut.
I'm finished.
Yes. Was this multifocal ERG done before and after the injections? And how many injections were given?
Ma'am, 3 injections, 15 days apart.
All suprachoroidal?
Suprachoroidal, 2 ml suprachoroidal and 1 ml subtenons.
All the 3 times you gave suprachoroidal as well as subtenons?
In your presentation, you did not mention about the ethical committee submission and clearance.
We have taken all the ethical clearance.
That need to be mentioned in while presentation.
Okay.
And that number need to be projected.
Actually, it was very short time, 5 minutes, so I could not...
No, it need to be projected somewhere so that we can read, even if you do not...
42 eyes was taken as control as well as for intervention.
Okay. Thank you very much.
Is it a pilot study of sorts? Is it the first time PRP is used for suprachoroidal?
Yes, it's a pilot study.
It's a pilot study.
Yes, sir. It has also been accepted in an international journal, ma'am.
International?
International journal, Current Ophthalmology.
Okay.
But you have a very short follow-up.
No. There is a problem. 1 second. Any presentation, you need to give the consent for publication in IJ1. That's a part of this thing if you get the award. If the same subject is submitted somewhere for publication, probably that will be a problem.
No, sir. Recently, it has been accepted. When I submitted, it was not accepted at time. Then
again, it's a little bit, you are cautioning us. But this, I want to tell everyone. Okay? Thank you very much. And I will go on to the next speaker, Dr. Subodh Singh. Yeah, comparing the severity and treatment of ROP in preterm following assisted versus spontaneous conception.
Good afternoon, everyone. Myself, Dr. Subodh. My topic is comparing of severity of and treatment response in ROP in preterm baby who were born with the IVF assisted versus spontaneous conception. So, as we know, the ROP is a disease of retinal vascular and capillary proliferation affecting premature infants. India is currently facing an ROP epidemic. So, my study is a retrospective observation study at IRIS Super Specialty Eye Care Center, Ranchi from 2018 to 2022. Screening criteria was in accordance with the National NNF of India. Birth weight less than 2,000 gram. Gestational age at 34 weeks. Or gestational age of in between 34 to 36 weeks. If exposed to the factors such as prolonged supplementation of oxygen, respiratory distress, or blood transfusion. So the international classification of ROP guideline were used to record the stage of the location and sign of plus disease. Data were analyzed with the gestational age of birth, weight, systemic factors predisposed to ROP. SSP software were used for this. So there are few cases of ROP we got. This is a case one where we got the zone half ROP, AROP in both eye, which were treated with the anti-VEGF injection followed by laser. And this is a second case where we got a zone half ROP with some vitreous hemorrhage. Again, this case was treated with anti-VEGF injection followed by laser. This is this other eye which has vitreous hemorrhage got resolved. The third case is the ROP with the atypical atypical presentation with the ERM in this baby. Fourth is again a zone half ROP which was treated with the with the successful results. Case 5 again we got a very severe zone half ROP, and this is the left eye zone half ROP. So these were the cases we got in our study. So here we can see that the incidence and severity, we found that the main gestational, we got total 674 infants, 334 were the natural conception and ART 331. Mean gestational age was equivalent 31 weeks. Mean birth weight were lesser in ART group. ROP were more in 162, 55% in ART compared to 44%. Aggressive ROP again is more in ART 24% compared to 9.6%. Zone half ROP we got only in case of ART babies. Plus spectrum again is more in cases of ART babies compared to. Yes. Treatment outcome, we saw that in observation 65% of babies in conceptional age group they got resolved, but in ART only 29%. Only with the anti-VEGF treatment 2 baby got recovered with in ART compared to this. Conventional anti-VEGF and ROP treatment were given, which one ART babies need more of treatment, 33% compared to natural conception. Only a laser required, but it is again the more in ART compared to the conventional babies. So if you see the stage-wise type of ROP, we can see it's the babies are in the stage AP ROP are more common in ART babies compared to the conventional group. Again in table 2 we can see on gestational is again 32 to 33 to 34 weeks. The babies are more in ART babies compared to conventional age group. Again in compared to the birth weight we can see that the birth weight comparing in between 1500 to 1750, the babies with the ART having more ROP compared to the conventional age group. And again in more than bigger babies also we saw that the babies with the ROP are more compared to the conventional age group. So here we have seen some risk factor we have analyzed where we got the respiratory distress syndrome, neonatal jaundice, neonatal septicemia and neonatal hyperbilirubinemia were the main cause of this risk factors in these babies. So in discussion in our study we have reported a significant increase in incidence of ROP among ART babies compared to the natural conception group. Incidence of aggressive ROP and plus spectrum disease has also been significantly higher in among ART babies compared to the natural conception, where only 9.6 to 15.7%. So the difference of different outcomes in assisted conception babies have been postulated to be because of the gametes are exposed to a variety of drugs, physically manipulation, nurtured in potential hazardous condition. In our study cohort, combined anti-VEGF and delayed laser treatment at least 2 weeks after the initial injection resulted in satisfactory results. And conclusion, the data presented here shows a significant association between ROP in babies with ART, and number of babies requiring ROP treatment is more in ART group, combined treatment is more. in ART baby, there has been a significant incidence of reactivation of disease in ART compared to the natural conception group. RDS and or neonatal anemia is the main risk factor for this. So just the last slide conclusions. Based on our results, we propose ROP screening should be done up to gestational age 36 weeks and birth weight 2500 in ART babies. ROP babies born with ART should be followed closely and should be treated aggressively. And post-treatment, they need to be sterilization for look for recurrence. Although we need a more data and more prospective studies to support this. Thank you.
Thank you. Can I call upon the next speaker, Dr. Naresh Babu? Thank you very much for
Thank
this.
you, sir. Check. Good evening all, and thanks AIOS for this opportunity. Basically, it's a comparative study of using the PFCL without PFCL in case of giant retinal tears and their outcome. So we know by definition at least for 3 clock hours or 90 degrees along with PVD, if the tear is there, we call it a giant tear, and the incidence is around 0.05% and it varies also. So there are various causes. It can be idiopathic from trauma to high myopia or following laser or cryotherapy. Usually, previously they have been doing buccal. Now pars plana vitrectomy is the mainstay of surgical management in these cases. And despite the invention of newer techniques, the reattachment rate is not very high. And it ranges anywhere between 48% to say 100%. In the largest series, it's only 64%. So many of these go for re-RD either with the silicone oil or after the removal of the silicone oil. So basically, we want to compare the efficacy of two-stage surgery in which we use PFCL as a short-term template replaced with silicone oil along, in comparison with the conventional single-stage surgery following long-term. So it's basically a retrospective study with the 74 eyes of 68 patients over a period of 5 years' time. And these are the inclusion criteria, and these are the baseline data which we measured. So in the first stage of surgery, the patient underwent the vitrectomy. And after the complete vitrectomy, the PFCL is almost filled up to 60 to 80%, and it is topped up with silicone oil. And the patient is kept in supine position for 5 to 7 days, and later on we'll take the patient for second stage where we replace the PFCL with fluid air exchange, and then we do the lasers in the second stage and do silicone oil filling. And without this PFCL is the conventional surgery where we fill the silicone oil cavity, vitreous cavity with silicone oil after the complete vitrectomy and endolaser in the single stage surgery. So these are the pictures after doing the base shaving. In cases if it is needed, we peel the ILM and then we fill it with PFCL topped up with silicone oil so that there is no movement of the PFCL into the EC. In the other arm, we'll just inject. So these are the statistical methods. And we have not come across any serious adverse event because of the filling of the eyeball with the PFCL in that 5 to 7 days time. And if you see, the baseline is almost similar, but the initial vision in the PFCL group is slightly worse because we had a lot of PVR cases and the total RD cases in that. And this is the axial length. Most of these cases were emmetropic and very few were myopic. And mostly it is pseudophakic in both the groups. And there were choroidal detachment in 11% of the cases. The advantage of using PFCL in these cases is within 24 hours of retaining the PFCL in the eye, the CDs completely disappear, and thereby it is helpful for us to do the endolaser during the second surgery. And almost 13 cases had 13% had PVR changes in both the groups. When you see the final reattachment rate, it's close to 90% in the first group, compared to 18 out of 22, almost similar in the second group. But when it comes to the question of vision, the improvement is very marginal in the first group where we use PFCL, because the initial vision also was poor in that case. And PFCL was removed in most of the cases except for 7 in the first group, because we retained as there was inferior retinal detachment. So coming to the discussion, when we compare this short-term PP with the single-stage vitrectomy, the patients who underwent short-term PFCL tamponade achieved a better anatomical as well as the functional outcome compared to only silicone oil group, and the redetachment is much lesser in case of the PFCL group. So compared to our study, it is almost similar as far as the demography is concerned, the age group also, and we had almost 13.5% of the cases with PVR, and almost all of them settled in this case. So although PFCL is an excellent tool for intraoperative, very few people are using it for the short term or the intermediate tamponating agent. So it was first used as the tamponating agent for GRTs long time ago. And these are the studies which give very good results while using PFCL for the short term tamponade for the reattachment. Usually there is not much of toxicity which we have seen. Okay. So the basic limitation of the study, it's basically retrospective. Maybe an RCT prospective will be giving a very unbiased result for this particular trial. And the visual acuity in the cluster A where we use PFCL was very bad, in the sense comparatively lower in the initial phase. That's why the final outcome of 6/60 was lesser in the first group, and we need a larger sample size. But however, in conclusion, a short-term tamponade of PFCL with silicone oil and GRT-RD gives a excellent reattachment rate. In fact, the high specific gravity of PFCL helps us in flattening the retina, so that when we do the laser during the second stage, it takes up very well. So we have never seen any slippage or any macular fold happening due to this, and there is no need for any scleral buckle in these cases. And with this, it is easy for us to operate even PVR C3 and above also with PFCL as a tamponade. Thank you.
Since you exhausted time, probably we will not go for questions. But the only suggestion I would say that you need to analyze the cellular level damage, which is reported long ago, that over 2 weeks time, if you retain PFCL, there can be retinal neurophotoreceptor, mainly neurosensory layer degeneration. So you need to somehow rule out that.
Yeah, up to 3 weeks it's not a problem, sir. And second thing, oxygenation is better with PFCL than with silicone oil.
Yeah. Those aspects you need to consider.
Naresh, one more question. Sir, based on your experience now, do you think that short-term PFCL tamponade may be better in all retinal detachments?
In fact, I'll say yes. For all GRTs, default we go
all retinal detachments.
Yes, for retinal detachment also. In fact, in the second stage, we remove the PFCL. We don't fill it with silicone oil. We instead fill it with gas.
Yeah, this is the last talk of the session. We are very sorry for the neuro-ophthalmology people. They are waiting, but we have never wasted time in between, but it got delayed. Dr. Chintan, he is from Uttarakhand Ophthalmic Society. He is presenting on PFCL-assisted full-thickness macular hole closure, comparison and outcomes. Dr. Chintan.
Good evening, everybody. So, for the longest period of time, a standard 5-step approach for macular holes has been the routine care of management. But with these techniques, there has been a lot of failure rates, a very high failure rate because of various factors, most importantly, large macular holes which haven't closed. So various techniques were then invented, one of the more recent one being the conventional ILM peeling, making of ILM flaps. This significantly improved the success rate, more than 90% with most surgeons, but still there was an element of flap dislodgement and flap displacement, flap related complications which happened, especially during trimming the flap or during fluid air exchange when it used to displace, or even during an air gas exchange with a leaky cannula where the flap would displace from its normal position. Because of this, various visco devices were used to compensate for this flap related complications, but all of them had limited success rates. And this got me thinking about using of PFCL, especially because when you use it in a case of retinal detachment with a macular hole, as you can see here, the ILM flap becomes very sticky and easily maneuverable and has a stuck-on appearance. So using the same principles, and also I came across this study by Vishal and all, where they did not employ this technique for flap positioning, but they used it for easier ILM peeling, and they also mentioned the sticky nature of the ILM under PFCL. So using these characteristics, this is one of the first cases where I employed this technique. In this technique, a routine vitrectomy is done, as it is done in all cases, followed by making of the hinged ILM flaps, like we do in any other procedure.